Hello everyone, this is Azhar Hirani. Welcome to the first ever episode of Practice Unlocked. Today I have an amazing guest, Dr. Bhaskaran. Welcome. And also my co-host, Bhaskaran.
Yes!
Fun fact, guys, they're actually, Priya is the daughter of Dr. Vatsala.
I was in her womb.
So, Dr. Vatsala, 30 years worth of experience in psychiatry. That's amazing.
Yes.
And also, you are a table tennis champion?
I was back home in India,
Oh, I
right?
see. Where in India?
I'm from Madras, Chennai.
Very nice.
Now it's called Chennai.
Yes.
And I was playing table tennis for about 14 years. That is, I started when I was 12 or 13 years of age, and I played even during my medical school time. Actually,
Wow.
I had to take time off when I was in my second year of medical school. I'm the only person in the history of India, the medical student, to take time off and come back and rejoin the medical school after that.
You actually took off.
I took
to
off
play.
for about 3 months.
Amazing.
And this was in my second year of medical school training. And I went to play the Commonwealth Games in Melbourne, Australia.
Amazing.
And then went and played the World Championship in Calcutta.
Amazing.
And so we were trained in Patiala by a coach that came from Korea
Right.
for about 60 days. So we had all of that done before we went on our trip. So we were in training. So I missed school actually for 3 months. So when I came back, I had only 57 days to prepare for my final exam, my second year exam, which included looking at the anatomy, because the second year is anatomy and physiology and biochemistry. And all three I had to complete in 57 days.
Amazing.
And it was my professor was so proud of me. And he said, whatever it takes, I'm going to spend time with you every evening and make sure you learn it.
Wow.
So, of course, I didn't get very high grades. I passed the second year, and that is what happened my second year. But of course, after that, I didn't play for another year because my mother was very sick, so I was busy taking care of her. So that is kind of a brief history of
The
my table tennis career.
era. What year is this?
This was 19, I was in medical school in 74, 75.
Amazing.
1974.
And I'm assuming this is before you were born.
Yes,
correct?
way
Okay.
before, yeah.
I see.
But the one thing that she is leaving out is that she was number 2 in the country, number 1 female in India
Wow.
in table tennis,
Wow.
but number 2 to a man.
Yeah,
But
I mean, I
number one,
practiced.
I
I practiced quite a bit. I was very. One of the things that I learned as being a table tennis player, a professional table tennis player, that helped me even in this country is the fact that you put in a lot of hard work. A lot of hard work, you will achieve whatever you want to in your
Absolutely,
life,
yeah.
and that is something that came to me from back home, from India, that I was able to carry through even in my career here in the United States. Although I have played here too. I played with, I don't know, Kabat Jayant is one of the top players in India. He also moved to this country, and we played an exhibition match between he and I. This was in the early part when I came to this country. This was in 1984-83,
Wow.
and we played as a fundraiser for the Houston Police Department.
Oh, wow.
Yeah, so that was another thing that I
Nice.
did. Of course, after that, I was not. I mean, I was very busy with my practice, so I didn't have time.
Did you continue playing like socially here and there?
I have.
I mean,
on
the thing
and
is,
off.
once you become so good,
Yeah.
then playing socially is not as, because you're beating everyone.
Yeah.
I'm sure.
Back home, yeah. But I continued to some extent here.
Amazing.
But it is very hard to continue playing. Have a successful practice, raising a family. I've got 2 great children. I'm so
wow.
proud of them, and also being able to play. I'm an avid exerciser. I still exercise quite a bit. And that plays a very important part in my life too.
Amazing. And I know you have 30 years worth of experience in psychiatry generally, and I read your bio. I wanted to read it out loud, but you know what? I think you would do it more justice than I would.
Yeah.
So, please tell us about where did you go to medical college? And I believe you were in private practice, in public sector, and also group practice. So just give us like a rundown of your experience in the psychiatry field and any other medical field as well in your professional career.
Okay. I went to medical school back home in India. It's called Kilpauk Medical College. There were 4 medical colleges at the time when I was going to medical school. Right now there are many medical colleges and some are private colleges too. But I went to a government medical college, and its college was Kilpauk Medical College. I came to this country. I graduated in medical school in January of 1980. And I came to this country and I was working for the Indian Railways for about 4 or 5 months. And then I got married in September 1918. I moved to this country in November 1980. So in 1981, July, you have to pass all the exams. I was able to pass all of those exams. And in July of 81, I started the psychiatry residency program in Baylor.
Amazing.
And they gave me credit for my first year of internship.
Oh, wow.
Because I did a compulsory internship back home. So they said I did not.
Meaning India.
In India. So I did not have to do the internship in this country. So only do my 3 year of residency training. So which I did. And I had Priya during my 3rd year of residency training.
Amazing.
And so I had to extend my residency for a couple of months because of going out on maternity leave. So instead of graduating in July of 84, I graduated in September of 1984.
I see. And when you said Baylor, mean Baylor in Waco or
Baylor College of Medicine. There are only 2 medical schools in Houston. One is UT and the other is Baylor College of Medicine.
Very nice, okay.
So I'm from Baylor College of Medicine.
College of Medicine is here, but I know Baylor itself is in Waco.
Yeah, there is a university, right?
Okay.
Baylor University.
I didn't know there's a difference. Wow.
Yeah, there's a big difference. And one is a medical school, the other is, has all of the. So in September of 1984, I joined a full-time faculty to Baylor College of Medicine.
Amazing.
And that's when I worked for 4 years as an assistant professor of psychiatry, where I was able to teach medical students and residents. Mm-hmm. And I was assigned to the community mental health clinic as a medical director of that clinic. Mm-hmm. So after working 4 years, I worked about 2.5 years at VA hospital. So in all of this, it was an incredible experience for me about working with other people, providing excellent care, learning. Of course, I was trained very well at Baylor. We had a very good training program, psychiatry training program. So I left VA in September of beginning of 1990. I left Baylor. I left the full-time faculty and I wanted to do private practice. So that's when I started private practice in September of 1990.
Amazing. And what made you want to go into private practice at that time from Baylor, essentially?
Yeah, I actually went. It took me several months to, I know as a first physician, it's incredible. My knowledge of business was so limited and none. I would say none. Mm-hmm. And everything I learned as I was starting my business. And for a long period of time, I could not afford to support the overhead. And so I had to take a loan, which I did. And that was able to support my office expense, my staff.
And their payment, their loan repayment, essentially.
And I had to pay the loan off. But I said, I'm going to take this opportunity to explore the area. Because the area that I started was Pasadena, and there was no female psychiatrist.
Pasadena, Texas.
Texas. Mm-hmm. There was no female psychiatrist. There was only 3 male psychiatrists. I said, it's a great opportunity for a first female to come and start the practice. So my goal in the first 2 or 3 months was to visit all the family practice doctors. And I personally visited all of them. I did my own marketing. And I started building my practice in that way. So it took me about 6 to 8 months. I think one of the big things that the young psychiatrists who come out right now should know that they are going to put some effort, hard work in, so they can putting the effort. And you may not make that kind of income in the first 6 to 8 months, which is okay, but you should be able to bear that. luckily, that was not I was able to get the loan and was able to pay off the loan. So when I established myself in the practice grew very rapidly after, because I was able to go and visit with many of these family practice doctors, and they began to trust me. They used to send me patients, and that's how my practice grew. So I was a solo practitioner for about 10 years.
Amazing.
But the problem with solo practice is that you're your own, it's an amazing, you're your own boss.
Yes.
You dictate your own number of patients that you see, you have your staff, you have your space, everything is good, but you cannot go on vacation because there should be somebody covering your practice.
Okay.
When somebody is covering your practice, that means you have to pay them. They're not going to do it free of charge for you unless you have an arrangement with them. And that is when my mentor, I respect him a great deal, Dr. Mark Jacobs, he approached me. When he and I were working together at St. Joseph Hospital, I was doing inpatient work. I did most of my business.
St. Joseph Hospital, which is a governmental hospital.
No. St. Joseph is a Catholic hospital. It is a med-surg hospital with a psychiatric wing to it.
Got it.
So a lot of the hospitals in this, I'm sure you're aware of, in this you have a freestanding psychiatric hospital, and then you have psychiatric wings that are part of medical surgical hospital.
Right.
So you can have a medical problem on a psychiatric patient. You can immediately transfer the patient to the medical side. So that was the advantage of having a psychiatric wing to a medical surgical hospital, which is what I had a great experience. I did about 10 to 12 years of inpatient work. And that's when I met Dr. Mark Jacobs. He is my mentor, and he invited me to join the group. And that time, he was one of the founding members of the group called University Behavioral Health. It was the original group. Mm-hmm. So he asked me to join. But I thought through the whole thing, and then made the decision, yes, I'm going to join there. And the advantage of the group practice is that you have significant amount loss of control of your practice. It is a group setting.
Yeah.
And it is the whole thing is managed by the group of 5 or 6 doctors. And the amazing thing is these people who took me in as a member of the group, they treated me with same respect. Mm-hmm. And I was able to do very well, and they respected me, they trusted me, and we worked very well together.
How many were in the group?
At that time, we were only about 6 of us.
Okay.
6
Which
of
for
us.
Texas is a big group, because
Yes,
usually you
it's a
see Northeast hospitals have bigger groups.
Mm-hmm.
5-6 doctors is a very small group.
Well,
but
especially
in Texas,
in the mental health,
yeah.
especially in the mental health area, because there's probably not, like now there's probably a lot of psychiatrists and therapists available, but I'm sure back then there probably wasn't.
Not that many.
Yeah.
That is very true. So we had, and when I joined the group, it was amazing. I learned a lot about the business part of it. I knew what a business part of it was. A small business I was running because I was a solo practitioner.
For 10
I
years,
knew
right?
how. For 10 years I did it. Of course, I worked very, very hard to build the practice, but it was easy for me to join. But the advantage I saw was I could take time off, and I could have somebody else cover my practice.
Exactly.
And these were all quality doctors who were my business partners. And quality, they provide very good care. I respect them a great deal, and they respect me also a great deal. So that is one advantage I saw in joining that group. Mm-hmm. And that group has grown. And now it is 14 of us, and it's a different name right now. When we were initially part of that group, we were managing Prudential Insurance Company, mental health part of the Prudential Insurance Company. Right. So it is. So they were giving us, which is again a new experience for me. Where the Prudential Insurance Company gave so many dollars for the mental health treatment of the entire city of Houston, and we were able to provide the care for them within that dollar time frame, in the dollar framework.
I see. So was it like one of those insurances where this is how much we're willing to give? Anything you save, you get to keep a share of that?
Absolutely.
Okay,
and
okay.
that is how it was. And that, I don't know the exact
So it's
name
like
for
a
it.
capitated model. Is that what it's called? Or did you get any fee for service?
It was not fee for. I mean, we created our own fees for that because we
Amazing.
kept it within that frame, that amount of money that we got. We
course.
we had to keep it within that, and whatever money, yes, it was distributed as a profit to all of us. You know.
But you only took one insurance, essentially, the whole practice?
Right now,
or-
at that time, we only took one insurance. But what happened was they saw that we ran the business very successfully. What they decided to do is to manage it themselves. So they took the whole business to themselves. So we lost that part of the business. But
But
that is,
did they end up doing better or worse?
well, it's very hard. Prudential is no longer psychiatric services. They don't provide psychiatric services.
So that's our answer,
Yeah,
basically.
so they didn't do good. They should have left it with y'all.
You know, whenever corporate gets involved in the business, the medicine side of the business, it usually dwindles down.
Yeah.
Because businesses always think they can do better, which they can. But when it comes to the medical business, when you have the physicians
running it. I mean, it's amazing what a quality work. I mean, we provided even emergency clinics,
Wow.
Which was for those patients who did not have the time to see the doctor individually. They could come to this emergency clinic, and this was operated by one of the 6 of the doctors. And so we had an amazing setup that was in operation, but unfortunately, it was taken away.
Of course,
And
because
and
everyone
after
was
that,
bought into that practice that hey, the better we do, the better it is. It's one of those very rare occasions where it's a win-win-win situation.
Yeah.
Where it's number one, best for the patient because the doctor's taking an extra care of them. Because I believe seeing seeing a patient for a consult is cheap compared to if they end up in the ER. That is a big bill, and that's what you always try to avoid. Correct? As a psychiatric doctor.
Right. And of course, I mean, it was, but then that's how I came to know our CFO, who was an amazing CFO. And I think when we went through the pandemic crisis, we suddenly lost 4 staff. We lost 2 of them. Thanks to Priya came and worked for us.
Wow.
At that time, our CFO was able to hire
because
her.
of COVID,
Because of COVID, they just left the practice.
Oh, they left the practice.
They left the group practice,
Okay,
of course. And so what happened was the practice grew, and we were only paper chart, So we started incorporating at that time. We started incorporating the electronic health records.
And when is this? This is in.
This was it was about 10, I would say about 12, 13 years ago.
Okay, that's when everyone started, because I know because when President Obama kind of came into the office, he said, hey, you will get penalized if you use paper charting compared to the...
Yeah, and of course there were a lot of advantages.
Knew that was
And
one of
even
the
I think so.
and
but
Medicare
she
also
was.
provided incentive to convert into electronic health records.
That's what it was. It
There
an
was,
incentive,
and
yeah.
I was,
'Cause it was expensive.
It is very
It was very
expensive for us to even, and again, I'm saying we had a very good Dr. Jacobs, Monk Jacobs was running the organization. He was the president and he ran the organization. I mean, he was just amazing person. And the way he negotiated that contract for electronic health records was amazing. And, I was one of those who was totally against it. I'm so used to putting all the information on the chart. I'm one of those, and it took a long time for me to get convinced, but now I love it.
You can't live without it.
I cannot
right?
live without it. I just love it. And I'm one of those who completes charts. My charts is never incomplete. It's always complete. And so
Do you have a scribe when you go see a patient, do you have a scribe next to you, or you do your own scribing as well?
I won't do that, but we have a format. We have a format that is, we have
puts
have 2 components of the electronic records. We have a practice management component, and we have the electronic health record component. The practice management is the business part of it, where you're seeing the patients, the copay that's collected, the insurance company. So, and
That's
what
handled by the staff.
That's done by the staff. And electronic health record component is my information that goes into the medical record. And so there are 2 components to it, and we still have that. And I think the first we introduced the practice management component of it, then only the electronic health record came into existence. So it took us about I think about, I would say 2013 is when the electronic practice management part of it was introduced. And 2014 is when the electronic health records came into existence. So we became part of it. And of course, I love it. Right now, I love it. And it's very thorough. And of course, I'm not saying it's very expensive, but our doctors have grown. And the amazing thing is, and again, the same CFO is no longer in existence. We have a different CFO. She retired. Of course, she's been with us for over 25 years. And she finally retired. And we have a gentleman that comes in. Now, right now, I think part of joining the group, there's so many advantages. Besides, though it is run as a group practice, big part of is still individual practice. I dictate how long I want to work, whether I want to work the whole 5 days a week or only 3 days a week, what I want to work, all that, I make the decision.
Is it like RVU based, or are you guys shared expense model, or?
Yeah, it's very much, for my local is my office space, the rent is shared by the 3 doctors. We have 3 doctors in our location, 2 child psychiatrists, I'm the adult psychiatrist. So we share the expense of the rent there.
Right.
And then we have 4 staff. I have 4 very good staff. I'm very blessed, and part of the reason is I treat them as my very important person in my life, because I cannot be successful if they're not going to produce the same effect for me. They work very hard and they are very dedicated to me. So I appreciate whatever they do, and I constantly tell them, and they have problems. I respect their problems, and if they have to take time off to deal with it, I respect that too.
And that also coincides with you giving them proper pay, as well as
Absolutely.
bonuses and just different things that help motivate the climate.
Absolutely,
and the culture.
absolutely. Yeah. And that is one thing about the group practice is that, there are some changes that are brought up in terms of documentation, in terms of what needs to be done, in terms of this particular insurance company can only does this. So all of this information is done by our staff. They are educated.
Absolutely.
It's just incredible. I cannot be successful without them. I really can say that.
Yeah, of course. And then, but so your group has 4 practitioners, but your overall group, is that the total amount of practitioners?
We are actually 5 different locations. Okay. I'm in the southeast location where we have 3 doctors.
Mm-hmm.
Okay, and we have a Pearland location where there are 2 doctors.
Amazing.
And then there is San Felipe location where we have 3 doctors. Okay, and then we have Central location where the main office is. Loop Central location, we have about 4 or 5 doctors right now.
And do you guys have your own psych hospital? I know a lot of psychiatrists.
No, we don't have our psych hospital. The
Any affiliation?
Right now, the 2 doctors who do hospital. It's very hard to do hospital work these days.
Because
very hard
the
in the
money
sense.
ones, or?
No, it was not so much reimbursement, but. More or less, it's very difficult to manage because I was doing hospital work, So as I said, whoever works with me, I always respect their input. So we used to have a case manager whose main job was to contact insurance company and find out what they're doing. So, in the hospital setting, their main job was to do that. And I always included them in my staffing because they need to know what is happening to all my patients. So the system is very different right now. And it is very hard to get patients into the hospital, very hard to discharge patients, to deal with the bureaucracy, not only in the hospital, but also dealing with the insurance companies. So I don't do hospital work, I was doing, but I don't do it now. But even in our 14-member group, there are 2 hospitals that we use. They have a lot of problems with quality of care because they've gone through a lot of changes in ownership. So we try very hard to manage the patient in the office setting. If they're acutely suicidal, then definitely they have to be in the hospital.
So I do want to get into the kind of patients that you see And I know, in any practitioner, when they're practicing, it can be tough. You're dealing with all sorts of personalities. When you go home, you have to kind of switch that off. But also, number one, is there a call situation usually in psychiatry? You have to be on call at a certain time.
Well,
to get home,
because I'm part of, as I told you, when I was a solo
but
practitioner,
generally,
everything.
let's say generally as a
14 of us, we take calls. So I take a call maybe once. I'm covering for 14 doctors.
Okay.
Once in 2 or 3 months, I take a call.
But that's pretty
the whole
overwhelming.
weekend,
Yeah.
the whole weekend. But Monday through Friday, I take my own calls.
Even in the middle of the night.
If they call, yes,
Amazing.
I have to be available. So, but on weekends, we take turns. Only on weekends. But weekdays, I take my own calls. So
Amazing.
it's not that bad. It has not been that bad in your. Yeah, you're right. The type of diagnosis that I generally see, because I'm in private sector, I told you, when I was working in public sector, we dealt with a lot of the chronic schizophrenic, chronic psychotic patients.
Mm-hmm.
In the private sector, we deal with depression, anxiety, ADHD, bipolar disorder. This is the spectrum. It's not like I don't have schizophrenia. I do have a few patients who are schizophrenic in my practice,
Right.
but that's not my predominant practice. My practice mostly is depression and anxiety. It's very interesting, as I've seen in the last 30 years, the first 10 to 12 years of my practice was predominantly women that came to get help. Now I'm seeing equally men and women are getting help. And we're seeing all kinds of professions are getting help, from
Which is
nurses to even doctors, have medical students who get help. And, we have a variety of patients that come.
Amazing. And that's really important to actually seek help,
Yeah.
as patients.
Well, just being in the Asian community, culturally, mental health isn't really addressed or talked about. Like, it's kind of taboo. So now in 2023, since you started your career to now, are you seeing more people in the Asian community seeking help?
There has been increase, but not as much in our Indian Asian community, not many. I don't know why they don't reach out as much,
They're considered weak, I'm sure.
Again, there is a considerable stigma. I play a great deal when I see these patients. I do a lot of education, because the mental illness is not because you've not prayed hard enough. You're a bad person. Yes, it's a devil that's after you. We don't think like that. It is another medical problem, just like you have diabetes. And there are so many factors that play a part in how diabetes is managed, whether it is just medications or how your diet is managed. How your spouse is involved in your care for your diabetes management. All of that play a part even in managing depression and anxiety. How do you get the family involved, and how do you... So I always do an education of them that this is a medical problem. This is not that you're a bad human being.
It's not a personality trait.
Absolutely
Yeah,
not.
yeah.
But what I'm saying is, yes, it has been very difficult for the Asian community because, I'm bound by HIPAA. I'm bound by confidentiality. So I have some prominent people in this country, in this town, who are seeing me. But I cannot talk about that.
Of course.
I cannot even talk to them about it. I cannot talk to anybody about it. Even my staff are all, when they see these people in the grocery store, they don't even talk. They don't even go near them. They don't even want to say that they are part of us, because we're very, very concerned about confidentiality. Absolutely. And I don't think the Indian community has a good feeling for that. They are under the impression that I'm going to be gossiping.
Yeah.
I just cannot.
Of course, they require a lot of education on this.
Right, and there's a lot of education, and I was part of an organization called Daya. I don't know.
I've heard of it.
I was part of them for about 15 years. I have done work with them. I used to supervise the caseworkers that used to work for them. And I have seen a lot of, and I used to provide free psychiatric care for many of them.
Can you explain what DAIA is a little bit, so somebody that doesn't know?
Yes, DAIA is an organization. It's an organization just like Houston Area Women's Center. They primarily deal with domestic violence situation. mostly women, because there are some men who are also in domestic violence situation, and these people are either coming into calling the offices, their office, for help, for not only for monetary help, for social service help,
Absolutely.
homelessness. Many of them don't even have place. They usually we have to find either hotel and pay for the hotel. So it's a very difficult. Some of them have even the spouses take away their passport and take away the green card. So
you guys get help from the local law enforcement as well?
Besides the local law enforcement, we also provide. It's amazing. The organization has grown so much. And of course, I was part of this organization for over 15 years. So, but I'm not actively involved. I'm in the advisory board. So, what I'm saying is that is domestic violence situation is not in South Asian community. I see it even in
overall
in the American community, both whites, Hispanics, and blacks. Have the same problem, but. What I'm saying is, yes, I don't see that many people in the Asian community seeking out for help. Maybe they're going to somebody else. I don't know.
Because you're South Asian, a South Asian wouldn't want to South Asian wouldn't want to see a South Asian doctor for a
because they're scared of the gossip, maybe.
Within the community.
But we cannot.
But I guess to the outside.
For them, they're outside, right?
Yeah.
Absolutely.
And then one of the things is, you see a lot happen within your practice, in terms of psych patients. Do you ever feel that? How do you turn that off when you get home, and you're around your kids, you're around your spouse? For a physician itself, basically, do you do something mentally to help kind of make sure your work is at work and home life is home life? Is it hard to differentiate?
I think it was hard, but now I'm doing better at it.
After 30 years later, you're doing better at it.
Much better at it. My job is to keep work at work, and home life is different. But I do a lot of other things. I exercise, and of course I spend a lot of time with my children, which I paint, I read. So a lot of other things I do, and of course I socialize. We have with my colleagues quite a bit. I do some socializing.
Right.
We talk, and I think being a part of a group has helped me a great deal. Because I have the sense of camaraderie with them, a sense of feeling that. I can count on them.
Yes,
even if
you're not alone, in any situation.
Absolutely not, and which is very different from being a solo practitioner.
And let's say if there's a difficult case, do you guys amongst your colleagues discuss
Absolutely,
that case?
absolutely. That's what I'm saying. I had a very, very difficult elderly patient, and whatever I did, they were so committed to seeing me. They're not going to leave me. So I had to get a second opinion. So I called one of my colleagues in the central location. I told her, please, this is the gist of the case. Please see it and give me your feedback. And she saw the patient and gave me feedback. And the patient is doing well, of course, I'm using all the feedback. But yes, I think it plays a very big, important part in having colleagues in your office, because you can always consult with them, So, it is very interesting. We have one of the doctors who's going to join us from the PLN location. She wants to join our group. And she was saying, I've been alone for so long in my PLN location. I'm so happy I'm going to be with you guys. And you, especially you, with so much of experience, I'm looking forward to it. So that is it's nice to hear that from her.
Absolutely. So when it comes to, for current physicians that are psychiatrists, I have, I know a few of them, but not a lot of them. And I do see a lot of them. I know someone that's actually at Baylor. I know someone that's solo. I know someone that's in a group, but they do like psych hospitals together and, more ancillaries to bring in more revenue for their practice. Do you think financially going into a group practice or being a solo, solo practitioner or with the hospital? Financially, what is best for them? I'm sure there's trade-offs, there's pros and cons for each. So please kind of
Sure. But I
expand
probably
on
have
that.
experienced all of them.
That's why I'm so
in one
interested.
experience. So when I was a solo practitioner, and for about 9-10 years, I was a solo practitioner. At which point, I was doing a lot of hospital work along with office work. So I was seeing patients in the hospital and seeing patients. So you can get quite a bit income from doing hospital work. Your income is very high.
Is it contract based? Is it like hourly based, or is it?
It is number of patients you see. There's a contractual rate that they
Per
assign
patient or
per patient,
okay.
and how it is assigned per day that you see.
Mm-hmm.
You have to see the patient 6 days a week. You have to do rounds even on a Saturday, and if possible even on Sundays. I used to do rounds if there were patients that were admitted at that time. So hospital ways you can make money too doing hospital
I know.
work.
I've also seen hospitals hire their own staff nowadays, right?
Mm-hmm.
So I know that a lot of the contracting they're trying to cut down. Have you seen that in psych itself?
Not
because
so
I know
much.
like the primary care used to go to the hospital to do the rounds, and of course that is also because the patient can follow them back into their private clinic. But I know in psych it must be different.
In psych, it has not come there yet. We
Okay.
don't have hospitalists right now because
Okay.
there's not that many facilities and to take care of psych patients, that many
see.
facilities. We used to have a lot of facilities, and we used to have a lot of doctors who used to practice in the hospital. Even in my group, which are 14 doctors, only 2 of them actually practice hospital work. So when we refer patients, when I have very difficult patients, I usually call one of them to see the patient in the hospitals that they go to. So seeing hospital patients is a good source of income, but it also it's a two-edged sword, because you have to. When I was working at St. Joe's, which is a Catholic hospital, and I used to take call there. When you take a call, it is called once a month and for the whole week, and so you have to take every patient, even the patients who cannot have money to pay. You have to see those patients. So I remember my office manager would say, this is our time to write off, and let's say our prayers to the God. So we are writing off so much of money every because we cannot collect from those people.
Absolutely.
And so the hospital work is a two-edged sword. You can make quite a bit of money, but you can also lose a lot of money too. Okay, so I enjoyed hospital work because I like to work as a team. I like to work with nurses. I like to see responses of patients with interventions, and I was so happy with the treatment. But it was a lot of work, and so as you get older, you don't want to do that. So that's how I cut down my hospital work. But right now, I run a program in my office called Intensive Outpatient Psychiatric Group, these are patients who are in crisis, either at work or at home. They are in crisis, and they come to this program, and our job is to prevent them from being hospitalized. So I follow them very closely, and they attend the program Monday through Friday, and 9 a.m. to 12 noon. So because of the COVID, we are doing it as a video Zoom session, but otherwise they used to come to the office, and Monday through Friday. So these are the very difficult patients. So I have patients coming from Texas Children's Hospital, nurses or teachers that are from on the school district who are having problems with the students, or it could be our plant operators who are coming from plants, different work-related problems. They will be attending the program. So they usually are attending the program the 5 days a week. Our goal, they stay about 4 to 5 weeks in the program. We keep them off of work during the time when they're staying. So we give them all the tools to go deal with those problems. If they're not able to deal with it, they make the decision whether to stay in the program or quit the program.
Is there a fee for that program?
Yes, yes. And that's what I'm saying. It is a negotiated rate, again, with insurance companies. And, I was running the program for 6 years. I started the program in my office 16 years ago. So I ran it for 16 years. It's only in the last couple of months, I don't want to take on so much of work. I know it provides a lot of income, but right now my income is not. For me, I want to cut down my practice and do less work.
Work smarter, not harder.
Yeah, and that's why I think group practice helps as well as you taper down your hours.
My colleague has taken over, and I tell them, he's got 2 kids in college. I said that extra income is you can subsidize their college education, and that's what I tell them. So that's another way of making money, and the third way that I'm doing right now is we have a specialized treatment called transcranial magnetic stimulation, TMS it is called, and you can look it up and Google it and look it up. It is a new form of treatment, and the treatment provides care for treatment-resistant depression patients. So it is, I found, we've been running it in our office for the last 2.5 years. And I've had about 100 patients in it. 90% have done very well.
Amazing.
It's a very good treatment, and the treatment is, they put an electrode on the scalp, and they have electromagnetic waves that pass through the skull into the brain tissue, and it changes the chemicals in the brain.
Amazing.
And it is being offered. We provide it is 36 treatments. It is covered by insurance, and
all insurances.
Almost all of them cover it.
Which one doesn't? Like, is it like, TRICARE or like, is it Medicaid?
I don't know about TRICARE. I don't know about Medicaid. But the Medicare, traditional Medicare covers it. I'm the only one who takes Medicare patients. I'm
all
one
the
of
others
those,
take more commercial.
more of them commercial. I take the management. I'm the one of those. Although I don't get paid as well as the other people. It doesn't matter for me. This is something I want to do to the community. I want to treat the older patients. So
are you on like managed care contracts?
a lot of them.
Okay, because psych is huge in managed care.
Yeah.
So and how you handle the patients, because a lot of them are frequent flyers to the ERs.
Right.
And
we try very hard not to. We try very hard. That's what I'm saying. I take Medicare, manage Medicare, and commercial insurance, but the 2 doctors that I work with, they're child doctors. They only take care of 50% of their patients are adult patients, but all of them are children and adolescents. That's what
like
they
the
take.
chip plans and things like that. Or
We don't take Medicaid. That's a problem. We don't take
I see.
Medicaid. We only take Medicare. I'm the only one. And we are about 4 doctors in a 14-member group. We are only 4 doctors that take Medicare and manage Medicare.
Oh, got it. I see.
So many of them are only taking commercial insurance. But the advantage that I have with the group is that we are able to negotiate with the insurance payers because we are a large 14-member group. We can say, if you're not going to come, we have the option of coming out.
It's more power than just one. Like if you were solo,
absolutely.
you couldn't do that.
I could not do
flex
it.
the weight.
So I was going to get to that actually. So
Yeah.
that so you're currently in network with these insurance companies.
Many of the insurance
Right.
payers.
So if the patient wants to come see you, it's a lot easier because you pretty much almost a lot of the plans.
But the problem is we are so full.
Absolutely.
And it is very hard to get appointments, and that is why we are trying very hard. If we have doctors who are willing to come and join our practice, we have business. Because we have contractual agreement with so many managed care companies.
Absolutely.
So it won't be hard. It won't be like me. It took me 6 to 8 months to build my practice. It'll take a couple of months for them to build their practice.
How booked are you guys? Like
I'm actually booked 2 months.
wow. And
2 months.
And I know when I need a physician, when I call and there's a wait time, it's very discouraging, and I have to look for someone else. So you guys are already losing business.
That's a problem. We because our business is so full right now. And that's why I'm saying, if we have new doctors, and we're trying so hard to find new doctors.
Recruit doctors. So do you guys have any like mid-levels or PAs or nurse practitioners?
That is the part that we have. This is our group is the only group that does not hire mid-level staff. We are doing everything ourselves.
Any reason why?
That's a very good question, and that's what we're exploring right now.
Okay.
Because of the fact that we are not able to provide the service and we're having a hard time finding doctors. Mm-hmm. So we are looking at hiring nurse practitioners. We are looking at it. It's just in the very early stages right now.
But I guess that's kind of like another disadvantage, because if you, per se, one of several doctors want to implement something like that, you still need to consult the other members of the group,
yes.
and it has the majority rules. So that could be an advantage, but a disadvantage at the same time.
Absolutely. And
I'm sure they have a board and everything.
Yeah.
You have to
And
present
that is what I'm saying. I'm in the executive board. I'm one of the top 5 people who, I mean, we discuss all of these issues. But what I'm saying is, yes, it is something that is being discussed, and we are looking at it. We're looking at our risk management part of it, our malpractice insurance. We have to get everybody involved in this.
Absolutely, yeah.
So we are exploring that. To answer your question, yes, we are exploring that.
And someone might be, why would someone oppose it? Is it because they don't have as much?
No,
out of the 14 people, is all 14 of them are busy, or your pod of 4 are the busiest?
All of us are very, very busy. All of us very busy.
So I'm sure the incentive is to make sure we hire someone.
Yes.
The agreement has to be physician.
Yeah, I mean, the problem
versus,
the one is, of course, the liability issues, and even
sense.
if we are sued, we'll be sued. The supervising doctor will have to be sued. Will be sued.
Absolutely.
Just as the nurse practitioner is sued. So we're looking at the legal aspect of it, the risk management aspect of it. All
The
of that we are
cost.
exploring.
Yeah, the cost as well, because that's a huge factor for doctors.
No, it is not. Actually, we were looking at, we have created a pro forma. It's very interesting, our present CFO has created a pro forma along with our president. They're looking at 2 or 3 pro formas that can help. But, we have to get all of this cleared. We have to get a legal clearance. We have to get a malpractice insurance clearance. And we have to find space. We are all so full right now.
Wow.
So, ideally, I would like to have therapists. I don't even have therapists in my office. I was just telling my colleague last week, I said I had seen patients in my telemedicine. 4 of them were asking therapist. 4, and I have not a single therapist in my office.
In your office.
In my office.
But what about all 14? Does anyone else have a therapist?
They have, but they're all full. That's what I'm saying.
So what's stopping you from getting that therapist?
It's very hard to hire therapists. We are just in the process of. We are talking to a therapist that is leaving. The problem is many of them don't even want to work full time. They want to work part time, and it's very hard to pay your overhead expenses if you're going to work part time. We have the space to put people in, so there's a lot of factors that play a part in making this. I mean, we need therapists, we need nurse practitioners. Both of them we need. For us to. I cannot take on any more responsibility. I'm working 3 days a week. I'm cutting down my hours, but I've been with this organization for over 22 years. So,
is there overall in the United States? Is there abundance of psych doctors out there, or there's
absolutely
a shortage?
There's such a shortage of.
There's a shortage.
Shortage of psych doctors. And part of the problem
it's
is.
It's not a shortage of psych doctors. I think the patient population is growing.
Oh, absolutely.
That's what may be. Okay.
The patient population is growing,
yeah, exactly. Yeah.
But we are having an acute shortage of doctors. We're not able to have that many. And also, if you're coming out of residency program, there are full-fledged clinics that will hire you for almost what you can make from us, are already hiring. So why would somebody with a loan of $250,000, medical student loan, take on the 3-4 months wait to get a good income versus somebody being offered an immediate job which will offer enough money for them, and that has been a challenge for us, to compete with those people to find a doctor.
Absolutely. So in terms of like psych and income for generally, I'm not saying for you specifically, but for psych doctors, I know that I was involved in a ancillary business called toxicology, which we work with a lot of psychiatrists, which is urine toxicology testing essentially. And as a psychiatrist, you have to send a lot of your patients through that screening. Now, ancillaries like that help make physicians make extra money on the practice that they're already doing. So if they're utilizing a service, if it's legal, it's compliant, they're able to get paid from it as a partner, not per how many patients they send through, but through a partnership. Is there other ancillaries that other psych doctors can look into that they may not be aware of? I know you said TMS. I'm assuming that would be a program, let's say a psychiatrist in New York or Alabama or someone else some other state can look into. But I do know that state to state, a lot of laws differ in the ancillaries that a physician can be involved in. And of course, they have to be compliant with the rules and anti-kickback, antitrust.
Oh, absolutely.
There is what's the big one? I forgot. There is a
I know what you're talking about. That usually doctors get into trouble.
Yes,
for.
exactly. There's
you're right. I cannot.
It's a person's name or something.
Yeah.
But so is there ancillaries that you can?
It's very difficult to find. Because we're very, very strict. Even hiring nurse practitioner has been a challenge. Although we've been talking about for the last 2 months. It is still a challenge to get the process rolling. Even those things that can work. But in terms of other ways of making income, it's only related to psychiatry that we can make income. That is TMS is one, the group treatment is one other one. There's another way of making. Hospital is another way of making.
So do you go to when it comes to companies, I know you contract with companies. Did your group have to negotiate this program with the companies, or you negotiated that with the insurance companies?
With the TMS?
The where you said you guys meet group calls 5 days a week, where folks from bigger companies come and join, or you guys have the availability for these guys to kind of get on a call with you guys?
Well, the group calls I think she was referring to was the group therapy. So
group therapy. Yes.
So some patients will come virtually on the telehealth kind of side, where mom would probably look at the people and kind of have an open forum kind of thing and make sure that they're on the right course as far as their medication, their treatments, and
right, absolutely,
so on and so forth.
So all of that is related to psych treatment is what we do.
So basically to get that kind of business, did you have to negotiate with the insurance company and say, I will offer that, or with the companies directly? Or are they third parties?
So if you're looking into group therapy, yes, it is negotiated with the insurance company.
Directly?
Yes, directly. Insurance. And, they have a rate, everyday rate on that. So everyday rate, so patient attending 5 days a week, they'll be billed for 5 days a week.
Got it.
And, but they are giving you that rate, but we are hiring the therapist to run the program. So the cost of running the therapist, the cost of putting the program in the office, all of that is part of an expense.
Absolutely.
And so all of that is calculated as part of whether it comes under. Yes, it has been very successful because we are still able to maintain, I think they pay per day, if I remember right, the group therapy, it is $250 a day for the therapy. Of course, we have hired a therapist who's
per person, $250 per day per person?
Per day per person, right. That's one of the examples I'm giving you, And each insurance company have different things, yes.
Of course, they all have different rates, different...
Per day, And all of that, billing all of that, and, collecting all of that, and, negotiating all of that. All of that is done. We have a very strong office setting, not only in the central location, in our own location, because to put in the data that the patient attended 4 days a week or 3 days a week is done by my senior staff. She has to get the information from the therapist, either through a phone call, and once a week she has to send that information. The same way the TMS billing, it is done by them, but the Medicare part of the TMS billing is done by my staff. Wow. So they have to call. The TMS staff have to call my Corina, who's my office manager, and for her to bill at the end of the week.
Got it. So there are
so-
certain CPT codes related to that.
Oh,
Yeah.
absolutely, absolutely.
And that's why I guess it's important to have a good support staff, because if your support staff isn't trained efficiently or effectively, they can mess it up by putting in the wrong code. So then the
Absolutely.
patient doesn't, or the insurance company declines the
Absolutely,
claim
absolutely.
and doesn't pay it.
And that's
whatnot.
why the training is very important, you know.
Absolutely.
And that's why my senior, the office manager that I have right now, she's been with me for 25 years,
Wow.
you know.
25 years.
25 years.
Wow.
Yeah, she joined me when she was pregnant with us, her first son. Now he is in the military.
Amazing. Wow.
So what I'm saying is, we are very. I mean, she's very good. She's
Amazing.
very good.
How do
And
you
she's-
retain? First of all, how do you get talent for your staff, and how do you retain them as well?
you know,
Because that's a
I'm-
big challenge right now everywhere.
very big challenge. You know, I can say it has been a big challenge. You know, but I'm saying three of our staff have been there for a long time. Have been there. You know, for example, Leonardo, who's my office manager, she's been with me for over 25 years right now. And you know, she was trained by my office manager who retired, you know, Rebecca. And Priya remembers that because
That's a good
as
one.
kids, they used to come and do the filing. You know, Rebecca would ask them to go and file. You know, both Priya and Vijay have both come in and helped out. So Rebecca trained Leo. And Rebecca was with me for over 20 years. And she retired because of medical illness. I mean, she was medically ill. And so she retired. And Leo was trained by Rebecca. And she stayed and she trained my office manager, which is Corina. I didn't have Leo at the time. I already had Corina as my office manager. And then we have Angie, who's the older person. And she was with us. She left and then she came back. And right now we have another friend which we hired 2 years. My goodness, she's amazing, totally amazing. I am so amazed by her ability. And I feel like, you know, I'm talking about Reina. She's been with me now for over 2 years right now. But she is at the same level as my office manager.
So,
Wow.
what question in your interviewing process? Like what do you ask, and what is the best response to know? Hey, this staff member is gonna be a potential that might work. Like, is there a particular question? Is there a particular response that you know? Hey, this person will fit in this culture.
Well, I think the biggest issue that of course, we have to pay them good salary. You know, we have to pay
So
them.
that's very important.
Payment
Compensation
pays.
is
The
huge.
compensation is very important, and also, you know, what are the benefits of joining us? You know, what are the benefits? I mean, there are
You
so
guys
many-
provide benefits.
Oh yes, we are providing healthcare benefits. We provide retirement benefits.
That's important.
Yeah, those are important, and of course, sick leave. You know, private.
And that's tougher for solopreneurs, solo entrepreneurs to
Yeah.
provide those benefits. I know a
Yeah,
lot
the
of
benefits
people
play a very important part, and of course, you know, it is very hard to hire people. And I think we have two sets of interviews. I think Leo and Corina do the first interview, then they ask the doctors to do the other interview. You know,
It's very important. So they protect your time. And,
Absolutely. They
Yeah.
first.
So a good staff is always because of your most important, you know, value is your time. So they're basically saving your time, making sure the things that as a physician you don't have to do, they
Right.
take care of, and that's very
Now,
important.
I can tell you an instance, you know, where we had a staff, and she was determined not to get vaccinated. She told us she's not going to get vaccinated. So it was we were very, very concerned about when we start bringing patients in,
Yeah.
you know. And I know she can wear the mask, she cannot sit in the front desk, her job will be restricted to the office. So all of that, we were thinking ahead because we were not sure whether we want to let her go. But, you know, I was one of those who said, you know, if she really wants to be with us, we'll give her 6 months' time. Let her talk to her doctor and then come back and let me know whether she wants to work with us with this, you know, getting vaccinated and then working now. And so 6 months later, she talked with her doctor. She decided, it was not medical reasons. She just didn't want to get vaccinated. Okay, so she said, I'm not interested in getting vaccinated. I'm quitting the job. I said, okay, we let her go. And that's
This is 6 months. You guys gave her 6 months.
6 months time to think about it.
Got it.
You know, so we worked with her, you know, and of course, you know.
But the requirement that was there was because y'all do see a lot of elderly patients that have their immune system compromised. So that's a liability as a
Absolutely. And for as a group practice, and if we are not going to get her involved, she has to be physically in an office, away from contact of other people. If that is the case, then how can we operate in, you know, because when one staff is sick, the other will come into the place and pitch in. You cannot have that, you know, if a staff decides to not do it, you know, or cannot do it, you know.
Absolutely. No, I mean, there's so much financial vested within the employee,
right,
or your staff member, you know, then you want to make sure that to protect that as well, to protect, you know,
minimize the risk.
Exactly, minimize the risk, and that's totally understandable. Now, in terms of like, is there a reason why a lot of physicians don't go into psych, and maybe would you even recommend physicians that are, because psych is, I want to say, is there a fellowship after their medical school, or
no? You have to do residency to do medical school, and then you do 4 years of residency for adult psychiatry. But if you do child, you do 2 extra years, so it'll be totally 6 years after medical school for child psychiatry. And right now there is a great demand for child psychiatrists, you know.
Got it. Okay.
We don't have that many child psychiatrists, unfortunately.
Is there a reason why you think a lot of medical students may not?
I don't know. That's a very good question, and that's what we've been exploring. And I really don't know why there is less of the interest to get into psychiatry. I don't know.
And I know there are a lot of specialties where if you do one specialty, you're allowed to do, you know, like a similar specialty. Like, I mean, I'll give you an example. A internal medicine doctor
can do gastroenterology.
Exactly.
Or cardiology.
Exactly. Certain you know, certain cases or just certain limitations that they have, you know, of course. Or a interventional radiologist does a lot of, you know, vein work and things like that. Is there something like that in psych?
Well, psychiatry and neurology, there is some overlapping. You know, yes. You know, I because I treat elderly patients, so I have patients with dementia, but I work very closely with. I mean, the workup is primarily done but the management of the behavior associated with dementia is done by me. But the workup is done by the neurologist. So I work hand in hand with the neurologist. So yes, there's some cross, you know. And I also work very closely with OB/GYN doctors dealing with postpartum depression or, you know, depression and anxiety associated with, you know. So we work with OB/GYN doctors. You know, that's another thing that we do. I work with a lot of family.
But can a neurologist be starting a practice for psychiatry, or no? Because you know, internal med can do.
No, you cannot start a practice, but a lot of the neurologists treat psychiatry. In many of the psychiatric patients get first treated by the family practice doctor or the internist.
Got it.
Okay, they come to us when they are having difficulty managing, because a lot of my patients who come from family practice doctors, they've already taken these medicines and it's not working for them, and that's why they get referred to me. Okay, so there is a lot of taken care of by the family practice doctors and internists. A lot of them take care of these patients before they send it to us.
Amazing. And then, and I believe, is your spouse also in the same, you know, same medical field?
No, he's an accountant.
An accountant.
And he loves business.
So he's counting your money that you're making.
I don't know about counting my money, but he loves the business part of the accounting, you know.
Amazing.
The amazing thing is, you know, I run my own business, he runs his own business. Amazing. So, you know, it's like, there's nothing like we, you know, of course he does, he files all my taxes and all that, you know, you have to do these monthly taxes you have to send, and every 941 you have to do every quarter, and there are forms that's a little above my head.
Yeah, it's above my head too. Trust me.
So I think those kinds of things, yes, my spouse will probably be doing that.
And in terms of, because I know a lot of, has he ever been involved in the practice, meaning from a business side of things? Because
Yes.
I've seen
When
a
we
lot
were, when I was a solo practitioner, he used to do a lot more work. But as a group practice, even
that's the benefit of the group practice is essentially 13 others that are family. that are working
there's
together to make it a
there's no
success.
need for anybody else to be involved.
Absolutely.
So
Because you have your own CFO, you have
right,
your own managers.
everything is going to, except that the money that I make, the taxes that I have to pay, those are the kinds of things that he helps to do it.
Amazing. And the reason I asked, I know because a lot of successful physicians that I've seen, especially the solopreneur, the entrepreneur that does private practice, usually their spouse is involved in some capacity, usually in the billing side, or usually in the as a practice manager. And I've seen a lot of those practices flourish because as a practitioner, you're so busy seeing patients, and then at the end of the day, you have to do all the charting. It may not be paper charting, but you have to get caught up on your EMRs. Then who has the time to really look at, hey, is your staff, are they collecting the right way? Is the CPT code that's supposed to reimburse, $9 that you have to bill for 10 days straight?
Yeah.
It's so complicated.
Yeah.
To really go in through the minutia. It's hard for a physician as a practitioner to do that. So usually I've seen you need the most trusted person dealing
Right.
with money in your practice.
Yeah.
So of course you can hire for that, but who's going to be your most trusted person? Someone in the family, and usually you've seen that a family member doing the collections part or the hiring.
You're
part.
absolutely right. You're absolutely right. But the amazing thing is, even from the beginning part of it, he was not so much involved in this whole process,
Right.
And of course now he's not anywhere involved, because everything is done. We've got it systematic, done so well. Our system is so well organized. It's like a machine that is.
Yeah, I mean, not to speak out of turn and not just because she's my mom, but when I was working on the business side of things, her office ran the most efficient. They didn't have a lot of money due with their patients. Their collections were on point. It was rare that the insurance company wasn't paying a claim or getting denials. So her staff her office really runs really efficiently.
Which is very rare because to run an efficient office, it takes a while. You got to have that vision to run an efficient office because a lot of times people just leave it just leave it in the hands of a practice manager, thinking that is
But
the right way of doing it.
I make it a point to, if I don't know anything, I will go and ask them.
Love it.
Explain it to me.
They're part
I
of your
don't
team.
understand it.
Yeah, they're part of your team, and you're
Yes, and that's the way I see it, and they have no problem explaining to me. I mean, the business part of it, the whole thing I have learned from my staff. I have absolutely zero knowledge.
I love
Even in my residency, nothing. There was never about private practice taught. Actually, one of my colleagues went to UTMB campus, Liz Hedden. She gave a lecture on practice management to the fourth-year residents who were coming out. She did a lecture on that. She said, I have to teach these people. I learned a lot only by practice, when I was doing the practice. I never knew anything when I graduated residency, and that's so true, and treating patients only 20% of the game. 80% is how you deal with your staff, how you deal with the patients. Compassion and kindness and respect is so important.
Absolutely.
I mean, they are another human being. You just listen, and they say, "My goodness, thank you, doc. You listen to me."
Bedside
that
manners
is
everything.
Yeah.
Bedside manners in a
And
practice
it is amazing
everything.
what the patients did,
Yeah.
the expectation, and that is what I see myself have grown in this. From what I was, when I was, looking at how can I make things better. How can I fix this problem? To what I am seeing right now is, how can I make their lives better? not fixing the problem, how can they be happy?
Yeah, I love it.
What is important for them is more important than what is important for me. It doesn't matter what I want for this patient. What is important is what the patient wants for themselves. And that is what I tell my patients all the time. You tell me what you want, and I will do what you want.
No, I love it. And then, so 30 years. She's been in practice for 30 years, which is amazing. Now, where to now? I know you've already lowered your hours. The reason I'm asking this question is a lot of physicians I've seen usually don't have a succession plan, and they need to continue working because they have, physicians have, they get used to a certain level of income. Sometimes it's not necessary that they have, invested for extra income, or a lot of their income is just tied to their practice and their ancillaries. And then once their practice stops and the ancillary stops, then everything stops for them.
But the amazing thing is, that's what I'm saying, you were asking me how was my husband involved in this, I remember when I started the group practice, when we started the IRA, I remember we had SEP IRA, and, when I did the IRA, the same amount, when you're a solo practitioner, you have to do it for the same amount for the staff too.
Absolutely.
So there is limitations of what you can invest.
Absolutely.
So when I joined the group, my goodness, it opened my eyes to the opportunities, how much of money you can put aside. And I did not know this. Only after I joined the group, I knew it was about $55,000 to $60,000 a year.
Yes.
You can set aside by IRS.
Yeah, and these are pre-tax dollars.
Yeah.
They're tax deferred, essentially.
Yeah.
And I would fight with my husband and say, no, we don't have the money to do it. He said, no, we're going to find money. There is some way we're going to find.
Yeah.
And that good decision that I made, I am still seeing that good effect. Of course, now I'm not putting aside that money because I'm 67, going to be 68 years old.
Right.
So
Few
in
years.
about 2
You gotta
years,
start taking it out.
Taking it out, yeah.
yeah,
It's
so
like
there's no
72 and a
point in
half.
putting.
Yeah.
So
Maybe
there's
more.
no point in putting any more money. So I'm looking at, but what I've done is, I've done an amazing job. I have to credit him to a great extent to my husband, because he was the one who pushed me to doing it. Because I was the one who would say, because we have to cut on this, and we have to come up with this kind of money. But it's amazing. Those are the kinds of things, I'm not going to just rely on my income.
Absolutely.
There's
That
a
was
lot
smart of
of
you.
money that I have set aside as part of my investments. That will be there. I know it will be there.
Well,
Amazing.
I know there's something that my mom has shared with me that she probably slipped her mind, but because she has received so much from the psychiatric field, when she retires, she wants to donate her time to help people that don't have money,
Yeah.
that possibly
I really
have
want to
mental
do
health
that.
problems. That's her way of giving
I
back.
want to go
To-
back
to
and
humanity.
provide
Yes.
free service for homeless people, and I'm already approaching people to do it. I know I'm working Monday, Tuesday, Wednesday, 3 days a week. I'm going to work, but Thursday and Friday I'm going to set aside 3 or 4 hours of time. But I'm going to do telemedicine. I don't want to go anywhere.
Absolutely.
Just telemedicine of offering services, free services for the disadvantaged. I want to go back and do it.
That is amazing. Well, Dr. Bhaskaran, thank you so much.
Yeah.
We've really, really, enjoyed this session, and thank you for coming on.
Thank you for taking this time, because I'm not somebody who likes to talk about themselves, but
You did a great job, though.
No. It's very important
Yeah.
because there's no one really talking about these things openly. So other physicians can kind of take from that experience. There's literally no way. There's no book on it.
Yeah.
There is no one talking about it. There are people writing books on it, but they're like a marketing company, and it's very one-sided. Or any podcast that talks about these things, they're more financially kind of just talk about the investment side and things like that. But to actually run an efficient practice, EMRs, and again, I still cannot think of that anti-kickback rule in.
No,
in the
I'm
physician
trying to
space.
remember what that. I know
Yeah, I
the
have
word
no
that
idea what you're talking
I know the word that you're looking
Yes.
for. It's just slipped my mind too.
Yes. Exactly. So no, this is very helpful. 30 years worth of experience, and with I think we took maybe a little over an hour.
Yeah.
And going over this, so it's all condensed. And, you know, you're peeling all the layers for other physicians or other would-be physicians or anyone who wants to even get into psychiatry. Because it's a very rewarding field.
Yeah.
Very rewarding field.
Very rewarding. And for me, it is. And that's why I cannot retire.
Wow. And,
I love what
Yeah,
I'm doing.
she cut back her hours, and then she calls me and she's like, I'm bored, so I think I'm gonna do half day Friday. And I'm like, Mom, whatever makes you happy, it's fine.
No, I love it. No, as long as you're giving back, and
You're
it's amazing that you're
and
wanting to
I'm
give back.
most
to the
probably
community.
going to work that half a day as working with the homeless people. I mean, there is a person that I've reached out to find out. She's in the board of this homeless organization, so I'm going to see how I can get involved.
Yeah.
Perfect. Well, you know, this is fantastic. Thank you so much.
Thank you so much.
Yes.
I appreciate it.
Yes, of
Thank
course.
Thank
you.
you, Mama.